And today we're going to look at a very, very interesting topic called anemia. Okay, anemia is a common condition which is found in our setting, and it's not. I would just like to say that by starting this presentation, there's a common misconception that anemia is a diagnosis. Okay, anemia is not a diagnosis, and it's always secondary to something. Okay, so I would like to focus on how we can understand anemia and how it is important for a good healthy personnel or a doctor to understand how to read the full blood count, hemogram, okay, hemogram interpretation. Okay, my name is Dr. Sandom Kandawere, a caring practitioner at Levi Mwanawasa Teaching Hospital. Okay, so I would like to start this topic by saying anemia is just a condition in which the number of red blood cells or their oxygen carrying capacity is insufficient to meet the physiological needs. Okay, it may vary by the age, it may vary by the sex, the attitude, smoking, and the pregnancy status. Okay, you know that in pregnancy there's a high demand of oxygen concentration due to the mother carrying the fetus there. So anemia is just a condition in which there's reduced oxygen carrying capacity to meet the physiological needs of the body. Okay, according to the World Health Organization, the criteria for anemia is hemoglobin. Okay, hemoglobin less than 12 in a non-pregnant woman, and hemoglobin less than 13 in males, okay, is classified as what? As anemia. Okay, in anemia in pregnancy is defined as hemoglobin concentration less than 11 grams per deciliter. Okay, so in non-pregnant women it's a higher ratio, it's 12, it's less than 12. Okay, in men it's less than 13. Then in pregnant women it's less than 11. Okay, so these are just the statistics. According to the World Health Organization, it's estimated that the prevalence of anemia in India is about 42% in women and 30% in the young men. Okay, at the range of 50 to 59 years. Okay, with that said, we just want to show you that anemia is a very, very common condition, and it's usually um, it's usually very common in our setting that we can't neglect talking about anemia or having understanding of anemia. Okay, anemia is graded according to the parameter which we talked about, the hemoglobin concentration. Okay, we've got mild anemia. Okay, which is we've got mild, moderate, and severe. Okay, so in mild anemia the HB limit is less than 10. Okay, it's less than 10. Okay, then in moderate anemia, we have got the hemoglobin concentration is 10 to 7. Okay. Then in severe anemia, it's less than 7 grams per deciliter. Okay. So you just need to have a good understanding of what these values are for you to get a good understanding of anemia, because we're using the hemoglobin concentration. Okay. Now, what is the etiology of anemia? What is the etiology of anemia? Okay. Anemia is comprised or is categorized into three common etiologies, or how it happens. Okay, so there's anemia which happens due to blood loss. Okay, this is mostly common in the trauma patients. Okay, in the trauma patients, they come to you in your setting and they're bleeding heavily. Okay, so in such patients, the common type of anemia you'll find is it's it's a hemolytic anemia. Okay, there's it's a normochromic normocytic normochromic anemia. Okay, then we have got these patients who keep losing blood. Let's say they are undergoing continuous operations. Okay, so in such patients we know that there is continuous blood loss. Okay, so that's the first category on how anemia takes place, the etiology. All right. There is another process which we call the impaired production. Okay, this is what we call hyper proliferative anemia. What do we mean? Okay, in this type of anemia, the body is not producing enough to meet its physiological needs. Okay, so these types of anemia can be due to the diet. Okay, it can be due to anemia of chronic illness. Okay, so we have got iron deficiency anemia, we've got megaloblastic anemia. When we say megaloblastic anemia, what we mean is that the MCV, the mean capsular volume of the red blood cells, has increased in diameter. Okay, it's greater than 100. So the cells are large in size. Okay, the most common types of megaloblastic anemia we have are due to vitamin B12 and folic acid. Okay, the other cause of impaired production in anemia is myelophasic or infiltrative type of conditions. Okay, we also have a plastic anemia, which can be congenital or acquired. Okay, the other thing we can talk about is increased distraction. What do we mean increased distraction? In hemolytic anemia, we've got conditions like sickle cell disease. In a sickle cell patient, you will find that there's increased rapid destruction of the red blood cells. So you find that these patients, instead of having enough red blood cells, they are always in less surplus, because these patients keep destroying their own red blood cells. Okay, so we have got conditions which we say are extrinsic to the red blood cell. We've got autoimmune conditions, infections. We've got physiological or chemical agents. Okay, so the other thing we can talk about is membrane defects. Okay, we've got enzyme deficiencies, which can be metabolic. Okay, we've got hemoglobinopathies. Okay, so all these things can cause increased distraction. Okay, hence causing a hemolytic anemia. Okay, there's this slide here which is explaining more in detail. Okay, we've got decreased red blood cell production, which can be plastic anemia. Okay, iron deficiency anemia. Okay, so there's decreased red blood cell production. Okay, it can be due to the diet. It can be due to conditions like anaplastic anemia, which can be a congenital type of anemia, and thalassemias. Okay, so we've got plastic anemia, iron deficiency anemia, and thalassemias under the what? Decreased red blood cell production. We've got increased red blood cell destruction. Okay, under increased red blood cell destruction, we've got conditions such as sickle cell anemia. Okay, we've got hemoglobin C anemia and G6P deficiency anemia. Okay, so there's the other thing which can cause the other etiology of anemia, which can bring about anemia, is increased destruction in the extra capsular volume. Okay, we've got things like hemolytic anemia, which we've talked about, which is mostly common in people who are losing blood. Okay, especially trauma patients. We've got autoantibody induced anemia. Okay, we've got anemia associated with drugs and toxins and also poisonings. Okay, so under the etiology, it's very important to know how anemia comes about due to the etiology. So that's the type of classification. So anemia has got two classifications. The one which we've talked about, which is the etiological classification, and there's the one which the one we're going to talk about, which is the morphological classification. Okay, under the morphological classification, it is very imperative for you to know that when you order a test for anemia to be done, let's say it's a full blood count. Okay, you have got certain parameters such as the mean capsular volume, mean capsular hemoglobin concentration factors, which are going to show you a picture of what's happening to the red blood cells. Okay, so that's what we call a morphological type of classification. It's just you seeing a picture of what's happening to the red blood cells, and it's going to help you to tell us or to know what type of anemia we're dealing with. Under etiological classification is due to the factors which are causing this anemia. What factors can cause that anemia? Okay, so as I was saying, morphological classification, we've got size, shape, and color. Okay, we've got the size, shape, and color. So when you take your when we get blood from you and take it to the lab, okay, what we are going to see there when we do a full blood count, they're going to tell us the size. Okay, if it's normal size. Okay, it's going to call normocytic. Okay, if it's reduced size, it's less than 100. We're going to call it it's less than 80. Okay, 80 to less than 80 to 100. Okay, so if it's just less than 80, let's say, it's going to be called macrocytic. Okay, if it's greater than 100, we're going to call it macrocytic. Okay, less than 80 is going to be called macrocytic. Okay, so according to the shape, they can be spirocytes. They can also be what we call dipanocytes. Okay, dipanocytes. We can also have according to the color. Okay, so what thing on the hemogram or on the full blood count tells us about the color? It's called the mean corpuscular hemoglobin concentration. Okay, when you see a full blood count and you look at the mean corpuscular hemoglobin concentration is less, you know that this cell it's reduced its color. We're going to call it hypochromic. Okay, if it's within the normal range, it's going to be what? Normochromic. Okay, if it's above the normal range, we're going to say it's hyperchromic. So it's very important for you to get familiar with these terms because we want you to use them in answering certain questions in your exam, or answering or telling us a diagnosis of anemia, whether it's iron deficiency, if it's megaloblastic. Okay, the picture, is it normocytic, normochromic anemia? Is it microcytic hypochromic anemia, which is found in iron deficiency? Okay, is it a macrocytic anemia? Okay, so we need to know the full blood count interpretation on the peripheral blood smear to get to a good clinical programming, or to help us understand what's going on with the patient. Okay, so we further talk about the morphological types. Okay, if you find that the morphological types, the mean corpuscular volume is less than 80, what does that imply? Okay, you're going to start thinking of what could cause this diagnosis, what could cause such a picture. Okay, so if the microcytic is less than 8 ferroliters, okay, you're going to know that this is what we call it's going to be called microcytic anemia. Okay, macrocytic anemia, we've got a mnemonic called liters. Okay, we've got one, it can be due to lead poisoning, it can be due to iron deficiency, it can be due to thalassemias, it can be due to sideroblastic anemia, and anemia of chronic disease. So microcytic anemia, these are the causes. So in the exam setting, when we ask you to say name the causes of macrocytic anemia, okay, you're going to tell us iron deficiency anemia, lead poisoning, thalassemias, sideroblastic anemia, and anemia of chronic disease. Okay, all right. So according to the mean corpuscular volume, if it's greater than 100, you know that this is a megaloblastic picture. And the two most common causes of a megaloblastic picture, we've got vitamin B12 deficiency and what? Folic acid. Okay, which ones are we going to do? Okay, what are the causes of this megaloblastic picture? We've got liver disease, we've got alcoholism, we've got hypothyroidism, we've got myelodysplastic syndrome. Okay, okay, so these are the ones I want us to focus on: the liver disease, the alcoholism, myelodysplastic syndrome, and the hyperthyroidism. Okay, and in some cases it can also be due to hypothyroidism in patients who come to our setting. Okay, normocytic anemia. Okay, normocytic anemia, meaning the picture, the mean corpuscular volume is normal. It's between 80 to 100. So when it's between 80 to 100, you know that this patient has got normocytic anemia. It can be due to trauma, okay? It can be due to trauma, or it can be due to recent blood loss, okay? So those are the causes of normocytic anemia. The other causes, it can be also present in anemia of chronic disease. Okay, it can be anaplastic anemia. It can be chronic. It can be chronic kidney disease. It can be a hyperthyroidism. Okay, uh, so these are some of the presentations or the causes we need to know when we talk about anemia. Okay, so we're just going to further talk about the morphological types, and we said under morphological types we've got the mean the red cell size. Okay, the red cell size can be normocytic, it can be macrocytic, it can be macrocytic. Okay, depending on the MCV ratio which we've been given to. Okay, so the other thing we need to know that mean capsular volume is just indicative of the average volume of the red blood cell. Okay, so the formula for mean capsular volume is the normal range. Let's just say the normal range is between 80 to 100, but some books can tell you to say 80 to 90. Okay, either ways you have to know that what they're talking about here is just the size of the red blood cells. Okay, so we move on to the mean corpuscular hemoglobin concentration, which is just indicative of the amount of hemoglobin weight per red blood cell. Okay, so in this one, don't get confused. It's just talking about the concentration of the RBC. Is it what is the quantity? Is it in the normal size? It's just indicative of the color. Okay, yes. So after we've talked about all these things, we're going to say we have already mentioned to say we've got all these types of anemia. Okay, so we're going to talk about the macrocytic normochromic anemia. We're also going to talk about the normocytic normochromic anemia and the macrocytic anemia. Okay, so what are we trying to tell you here is that the size of the red blood cells in a macrocytic anemia is smaller than normal. Okay, then the size of the red blood cells in a normocytic anemia is just normal. It's between 80 to 100. Okay, in microcytic anemia is larger than normal. Okay, there is central pallor. Okay, so the central pallor in macrocytic hypochromic anemia, which is mostly found in iron deficiency anemia, is about more than 1/3. Okay, so in this type of anemia there's reduced color concentration. That's why it's hypochromic. Okay, so it's good to understand this, because when the patient presents to your setting, when you see the pallor, you can start querying what we call anemia. Okay, so patients with iron deficiency anemia present with what pallor in our setting. Okay, central cyanosis, such things. You have to look out for these things. Okay, when you check their fingers, you see signs of colonicea. So these are important things to know to help you evaluate the patient better. Okay, we look at the mean corpuscular volume in macrocytic hyperchromic anemia. Okay, it's the mean corpuscular volume. The size is reduced. It's less than 80 ferroliters. Okay, in a normocytic normochromic anemia is between 80 to 100. Okay, in a macrocytic anemia is increased, is greater than 100. And we said the most common causes of a macrocytic anemia is vitamin B12 and folic acid. Okay, the mean corpuscular hemoglobin concentration under this type of anemia is reduced. Mean corpuscular hemoglobin concentration, I just want you to think of the color. Okay, the color of the red blood cell. Okay, so it's reduced, meaning the patient is going to be hypochromic. They're going to have hypochromic red blood cells. In normocytic normochromic anemia, the MCHC, the mean corpuscular hemoglobin concentration, is normal. Okay. Then in the macrocytic anemia, the mean corpuscular hemoglobin concentration is also normal. Okay. Examples of these conditions we've already mentioned to say macrocytic hypochromic anemia. The most common thing we should come to your mind is iron deficiency anemia. Okay. So in a normocytic normochromic, the most thing we should come to your mind is trauma patients and patients who are having blood loss, okay, or anemia of chronic disease. Okay. Then in macrocytic anemia, we've talked about deficiencies like vitamin B12 and folic acid. Okay. So as you can see in this picture here, the red blood cells in the first one in a macrocytic hyperchromic, it's there's central pallor there. The central pallor. Okay. The normal type of normocytic normochromic cell should have less central pallor on the middle, and it should be very red in color. Okay. As you can see, the macrocytic anemia there is very large in size. Okay. Hope this explanation makes a lot of sense. Okay. So the other thing we're going to talk about is the pathophysiology of iron deficiency anemia. Okay. In the pathophysiology of iron deficiency anemia, same things apply. Okay. What happens is that there is iron reduction or iron depletion. Okay. Iron is adequate to maintain the normal hemoglobin level, and only serum ferritin is decreased. Okay. So the indicative parameter of iron deficiency anemia is what we call serum ferritin. Okay. We look at this value to tell us are we having iron deficiency anemia. Okay. It's important because it's the carrying capacity of iron in the body, the serum ferritin. Okay, don't forget that it's the carrying capacity of oxygen of iron in the body. So we need to know if it's in high amounts or if it's in low amounts. We know that this patient has got iron deficiency anemia. Okay. We further look at the iron deficiency electrophoresis. Okay, there's lowering of iron, serum iron, okay, and transferring saturation levels. Okay, so all these factors can contribute to a patient having what? Iron deficiency anemia. Okay. So with that being said, we've talked about the morphological classification. We've also talked about the etiological classification. Okay. So it's just very important to understand the picture of how it's going to show us when we do a full blood count and differential count in a patient we are suspecting anemia. Okay, we should be able to see what's going on. A good health practitioner or a doctor should be able to read for us a hemogram. Okay. Now, with that being said, we need to understand that what are the clinical presentations of someone who comes with iron deficiency anemia. Okay, with a picture of a normocytic hypochromic anemia. What is the picture there? Okay, you need to understand that these patients have they'll present with fatigue, palpitations. Okay, their breathing increases. They are weak usually, and they are irritable. Okay, so when we examine them properly, we're also going to find what we call angular stomatitis, okay, or esophageal webs, okay, which will be causing a dysphagia. Okay, in these patients, they present with a syndrome which we call Plummer-Vinson syndrome. Okay, they will present with a microcytic hypochromic anemia. They will present with atrophic glossitis and esophageal web. So that triad is indicative of Plummer-Vinson syndrome in a patient with iron deficiency anemia. Okay, so some of these patients may have a congestive heart failure due to severe anemia. Okay, you will find that there is reduced carrying capacity of oxygen. Okay, the heart is unable to meet the demands of the body to supply that oxygen. Okay, hence they'll present with heart failure due to secondary to severe anemia. Okay, so always heart failure, or sorry, not heart failure, anemia is always secondary to something. Anemia is not a diagnosis, it's always secondary to something. Okay, so the other thing we need to talk about is the central nervous system. These people will present with uh, what we call pica. Okay, pica, they will just be unusual cravings for substances which have no additional value. They will crave for things like clay soil, even chalk. Okay, if that dirt they sell on the street, these people will crave for it. Okay, they also crave for ice. Okay, we call that pagophagia. Okay, they'll crave for ice. Okay, so that's indicative that this patient has got what we call iron deficiency anemia. Okay, so you need to know they'll have unusual cravings like pica. They'll crave for things which are like chalk or clay. Okay, they also crave for ice, which is called pagophagia. Okay, so amongst all those things we can talk about on the physical examination, when you're examining this patient, you are going to see on the lips, they're going to have cut lips at the edges there. Okay, that's what we call angular stomatitis. Okay, they're going to have a chronic atrophic gastritis. They're going to have spoon-shaped nails. We call those spoon-shaped nails colionica, colonicia. Okay. Yes, so those are some of the presentations we need to be aware of when it comes to iron deficiency anemia. Now, the other thing that we're going to do is when you're ordering for investigations for iron deficiency anemia, what you're going to talk about is what we call the iron profile. Okay, the iron profile. We're going to say I'm going to do an iron studies. Okay, but we just say I'm going to say iron profile or iron studies. So the iron profile is composed of several things. The most important thing on the iron profile is the serum ferritin, which is the carrying the thing is what carries the iron in the body. So it's indicative if you've got a normal iron level or it's low. So serum ferritin. Okay, so the normal level is about 15 to 300. Okay, nanograms per liter. Okay, the other thing on the iron profile is serum iron. Okay, so you need to check for the serum iron, you need to check for the serum transferase saturation. You also need to check for the total plasma ion binding capacity. Okay, total plasma ion binding capacity. You also need to check for the serum transferase receptor. Okay, we also need to check for red cell photo the red cell photoferrin. Okay, now when we ask you to do iron studies, it's important that you mention some of these things. What are you going to look for in the iron studies? You're going to check for the serum ferritin, serum iron, okay, serum transferrin saturation, the total plasma ion binding capacity, and the serum transferase receptor. Okay, so that's one of the pictures of how a patient with iron deficiency anemia presents. Okay, so the other thing we need to talk about is what we call a megaloblastic anemia. When we're talking about the megaloblastic anemia, it's just a type of anemia which presents due to the MCV, the mean capsular volume, being greater than what? Being greater than 100. Okay, what is the pathophysiology of a megaloblastic picture? Okay, there's impaired DNA synthesis. Okay, so in this patient, there's what we call vitamin B12 deficiency and folic acid deficiency. You know that there's impaired DNA synthesis. Okay, megaloblastic anemia is common due to the deficiency of vitamin B12. Okay, and also folic acid. Both are important for what? The synthesis of DNA. That's why we are saying in a megaloblastic anemia, there's impaired DNA synthesis. Okay, so what happens is that there's delayed maturation of the nucleus. Okay, the nucleus maturation is lags behind the cytoplasmic maturation. Okay, this results in abnormally large nucleated euthyroid precursors. Okay, so which are named as, which we call megaloblastic. So they just are abnormally large euthyroid precursors due to the what, to the lagging of the nucleus maturation. Okay, so there's impaired DNA synthesis there in the cell. Okay, so we also talk about cytoplasm. Cytoplasm matures normally. The red blood cells are larger than normal. Okay, we call them macrocytes. Okay, so we need to always think about such things when you're talking about the megaloblastic anemia. Okay, so what are the causes of a megaloblastic anemia? Okay, we've talked about vitamin B12 deficiency. Okay, what can cause vitamin B12 deficiency? Okay, the thing which can cause vitamin B12 deficiency is what we call there is decreased intake. Okay, inadequate diet. Okay, so we have got people who are like pure vegetarians can have at high risk of having this disease because they're lacking vitamin B12 due to their limited diet of just being a vegan. Okay, we've got impaired absorption. Okay, impaired absorption in conditions which are gastric, like deficiency of gastric acid or pepsin or the intrinsic factor in the stomach. Okay, so these patients who have pernicious anemia, okay, who are post operation patients who underwent a gastrectomy. Okay, let's say in a peptic ulcer patient, they went a gastrectomy, and now they will be having difficulties in the producing of gastric acid. We've got patients who are, we've got intestinal causes. Okay, intestinal causes, we have got loss of absorptive surface things like malabsorption syndromes. Okay, we've got diffuse intestinal diseases like lymphoma, we've got systemic sclerosis. Okay, and we've also got ileoresection. Okay, even Crohn's disease. Okay, so it's important that when I ask you what are the causes of iron vitamin B12 deficiency, all these points come out. You talk about decreased intake and you talk about impaired absorption. Under impaired absorption, you talk about the gastric causes, and you also talk about under intestinal causes, you talk about the intestinal causes. Okay, the other thing we can talk about is bacterial or parasitic causes. Okay, we've got bacterial overgrowth in the loops. Okay, and also we've got a fish tapeworm infection. Okay, we've got a fish tapeworm infection which can cause vitamin B12 deficiency. We've got increased demand in pregnant women, in patients with a hyperthyroidism. Okay, in patients with disseminated cancer. All these things should be talked about when you ask for what are the causes of vitamin B12 deficiency. Okay, we've got folic acid deficiency now. What things can cause folic acid deficiency? We've got decreased intake. Okay, what do we mean by saying decreased intake? We've got inadequate diet. Okay, inadequate diet. We've got alcoholism. We've got malnutrition. Okay, we've got impaired absorption as well. Okay, absorption states. Okay, so you need to talk about that as well. Okay, so we've got diffuse infiltrative disease of the small intestines. Okay, e.g. lymphomas. Okay, we've got increased blood loss. Okay, we've got increased blood loss. We've got increased demand in pregnant women. Okay, disseminated cancer. Okay, these patients are undergoing chemotherapy, so you need to make sure that you put them on prophylaxis for folic acid, because you know that the DNA, there is high DNA synthesis which needs to take place. So if it's impaired, it will cause some of these things. Okay, so we've got impaired utilization. Okay, some drugs can cause folic acid deficiency, such as drugs like an antimetabolite like methotrexate, which goes to impair the DNA synthesis as well. These are the chemotherapy drugs we're talking about. So you need to, each patient who are on chemotherapy, you need to supplement them with folic acid, so that you know that there's a balance which is going to take place. Okay, so hope this explanation is adding up, or it's making sense. So this is just a picture of the vitamin B12. Okay, vitamin B12, most of the time they have got what we call hypersegmented neutrophil on the peripheral blood smear. Okay, so it's important to understand that such patients, they have got hypersegmented neutrophils. Okay, so the other thing we're going to talk about is all these factors. You need to keep them in your mind, so that when you're asked what you're going to expect from you in a peripheral blood smear, it's easy for you to come up with answers. Okay, so what investigation can you do with someone who comes in with a megaloblastic picture? Okay, they're going to check for common deficiencies which are found in vitamin B12 and folic acid deficiency. Okay, so the most common type of you're going to order what we call biochemical test. You're going to order for serum homocysteine. You're going to order for a serum bilirubin, okay, which is mildly increases and shows mild jaundice. You're going to order for serum iron and ferritin, plasma lactate dehydrogenase, okay. We're also going to order for serum B12, okay. So the diagnostic test for vitamin B12 deficiency in our setting is serum methyl and when you order the biochemical test, they're going to find a serum methyl melanolic acid, okay. Serum methyl melanolic acid, okay. This is a definitive test for vitamin B12 deficiency, okay. So you need to keep in mind of this acid, okay, the serum methyl melanoic acid, okay. The other thing you're going to do for a patient with vitamin B12 deficiency, you're going to do a Sheehan's test, okay. You're going to check for absorption there, okay. So these are some of the tests which are important to know for vitamin B12 deficiency. When you ask what investigations can we do for vitamin B12 deficiency, you need to talk about all these tests we have just mentioned. Then the specific test for folic acid deficiency, you need to check for serum folic acid levels, which are usually decreased, okay. So those are some of the things you need to check for when it comes to patients with folic acid deficiency, okay. So with that being said, it's very important to always remember all these tests for the biochemical tests for megaloblastic anemia, okay. Okay, with that being said, we've got a condition which is mostly we find, but it's rare. We've got just to mention something on pernicious anemia. It's just an autoimmune disease, okay, due to the deficiency of the intrinsic factor, okay, so causing an impaired absorption of vitamin B12, okay. So pernicious anemia is a cause of vitamin B12 deficiency and megaloblastic anemia, okay. We'll further look at this pernicious anemia on its own later in a different setting, a different type of discussion. Okay, so that's mostly on anemia. Okay, we've talked about almost what we need to understand on anemia. Okay, we've talked about hemolytic anemia just due to the increase in red cell destruction due to trauma in most cases, okay. But there are other causes which can be inherited. We've got hemoglobin abnormalities, okay. We've got acquired genetic defects, okay. So we also discussed this in a different discussion, but it's just very good to give a highlight on what we're expecting, okay. So the other thing we need to remember, or we need to talk about, is how do these different types of anemias present on the peripheral blood smear. Okay, so what is a normal picture of a red blood cell? A normal picture of a red blood cell should be a biconcave. Okay, it should be flattened, okay, on the smear there. It should be round. It should be like a circle. Okay, it should be cyclic in nature. Okay, so when you see what we call polykylocytosis, variation in red blood cell types, just know that you're dealing with a severe type of anemia. Okay, when you see spirocytes, okay, you're dealing with, these are small, they are small and they are stained. Okay, they have got central cyanosis. You're dealing with hereditary spirocytosis or an autoimmune hemolytic anemia. Okay, when you see target cells, you're dealing with a sickle cell disease patient. Okay, we talked about sickle cell is one of the causes of anemia because of increased red blood cell destruction. You're also going to talk about hemolytic anemia. Okay, you're also going to talk about post-splenectomy. Okay, liver disease. All those present with what we call a target cell. Okay, then if you see sickle cells on themselves, these are thin, elongated, and curved cells. Okay, when you see such a cell, you think of sickle cell disease. We've got bite cells. Okay, these are just pairs of spicules. Okay, they are seen in G6P deficiency. Okay, we've got schistocytes. Okay, these are seen in macro angiopathic hemolytic anemia. Okay, so we've got acanthocytes. Okay, acanthocytes are just seen in liver disease. Okay, so all these cells, we've got a bar cell. A bar cell is seen in uremia. Okay, we've got pencil shaped cells. Okay, pencil shaped cells are elongated thin cells which are seen in iron deficiency anemia. Okay, we've got ovulates I've got ovulates oviocyte cells. Oviocyte cells are seen in hemolytic anemia. Okay, we've got teardrop cells. These are seen in myofibrosis. Okay, so there are quite a number of cells, and you just need to know the common ones. So if we talk about iron deficiency anemia, you need to think of the pencil shaped cells. We talk about sickle cell anemia, you need to talk about the sickle cells. Okay, we talk about polykylocytosis, you need to tell us that this is severe anemia. We talk about target cells, you need to tell us this is found in sickle cell anemia. These are common MCQ questions. Okay, so this is just a picture which is helping us understand more on what we've talked about. So it can be normocytic, it can be macrocytic, it can be macrocytic. Okay, it can be variation in size, it can be anacytosis. Okay, anacytosis. Okay, so these are just types of different variations on the peripheral blood smear. Okay, so you need to know the normocytic, the macrocytic, the macrocytic, the anacytosis, the anacytosis. Okay. Okay. The other thing I can talk about in the megaloblastic type of anemia, what you see is halo jelly bodies. Okay, halo jelly bodies. Okay, so we need to be very clear on that. Okay. All right, so we've done most of the things on anemia, but a presentation of anemia, we already said someone presents with fatigue, malaise, there'll be dizziness, there'll be irritable, there'll be fatigue, there'll be, in women, you need to ask a good history. When taking anemia, you need to take a good history, because women who present with heavy menstrual bleeding are also prone to anemia. Okay, so you need to ask them that, and also loss of appetite. Okay. Okay, so some of them can even present with syncope in the advanced stage. Syncope is just fainting. Okay, in the advanced severe anemia. Okay, so how do you get a history with someone who comes with with anemia. Okay, you need to ask them about the diet. Are they a vegetarian or a non-vegetarian? Okay, why are you asking that such a question? Because you know vegans are pre-exposed to what we call vitamin B12 deficiency. Okay, we've got chronic blood loss. Chronic blood loss, we've got menorrhagia and patients with hemorrhoids. Okay, we need to ask, especially in all women, you need to ask about the heavy menstrual bleeding. Okay, we've got drugs like anti-cancer drugs like the methotrexate we talked about. Those types of drugs can cause megaloblastic anemia, which is due to folic acid deficiency. Okay, so we've got all those drugs which you need to think of, and we've got drugs like quinine, okay, which can cause increased red blood cell destruction. Okay, we've got chlorophenaco. Chlorophenaco can cause anaplastic anemia. Okay, family history of anemia. Patients with sickle cell, you need to ask if they have got sickle cell, because you know there's it can be passed on and the patient cannot know, so you need to do a sickling test or an HB electrophoresis to just confirm if it's actually a sickle cell patient. We've got conditions like thalassemias. Okay, we've got patients with alcohol addiction. Okay, alcohol addiction causes a megaloblastic anemia. Okay, you need to ask about renal disease, uh, rheumatic diseases. Okay, you need to ask about the systematic symptoms like fever, weight loss, the constitutional symptoms like fever, weight loss, and night sweats. Okay, you need to also ask about obstetric and the menstrual history. So this is how we take history with someone who comes with what you're suspecting anemia. Okay, on the general signs there, the general signs, you see pallor, you see uh, um, edema, you see lymphadenopathy, you see petechiae there. Okay, you see the ectorus. Okay, you see systematic on examination, you see a flow murmur on CVS. You find a flow murmur, loud S1. Okay, you on the chest you will find crepitations, and per abdomen you find splenomegaly. Okay, so just investigations for patients who come with anemia, you need to do a full blood count and differential count. Okay, you need to do a reticulocyte count. You need to do a peripheral blood smear. You need to do liver function tests, renal function test, iron studies, which are comprised of serum ferritin, total iron binding capacity. Okay, all those investigations, the serum iron. Okay, you need to do vitamin B12 and folic acid level. Okay, specifically, you're checking for vitamin B12. You're checking for the methylmelanoic acid. Okay, for this folic acid, you're checking for the folic acid levels there. Okay, even in vitamin B12, you can check for the homocysteine levels as well. Okay, you can do a peripheral blood you can do a bone marrow examination, HB electrophoresis, to check if they're having a sickle cell. Okay, you can do a flow cytometry. You can do a direct and indirect COMS test. You can do a screening test for hepatitis B and C, just to check if there is chronic anemia of chronic disease. Okay, so this is just the approach on how to check for anemia. A low HB, you check for the reticulocyte count. Okay, the main guide should be your morphological type there. Okay, these are same things we've talked about, the causes of anemia based on the morphological types. We've got iron deficiency, microcytic, we talked about it, what causes it. Okay, macrocytic, we talked about the causes. Okay, so we need to just understand, even normocytic, according to the mean corpuscular volume, what can cause this type of what anemia. Okay, so that's all we need to understand. For microcytic anemia, I've got a mnemonic called liters. Okay, so we need to understand all these parameters. Okay, so in microcytic anemia, we've got lead poisoning, iron deficiency anemia, we've got thalassemia, we've got anemia of chronic disease, you've got lead poisoning and also zinc deficiency. In megaloblastic anemia, we've got vitamin B12 deficiency, folate deficiency or folic acid deficiency, and DNA synthesis inhibitors. Okay, so in that's in megaloblastic. In macrocytic anemia, and you've ruled out the cause that is not vitamin B12 deficiency or folate acid deficiency, you can also start thinking of other causes which can cause a big picture of like a big MCV, okay, greater than 100, but it's not vitamin B12 deficiency and folic acid deficiency. You can check for, so this macrocytic anemia is going to be called non-megaloblastic. So under macrocytic anemia, we've got megaloblastic and non-megaloblastic. If it's megaloblastic and the cause is vitamin B12 deficiency, okay, our folic acid, we call it megaloblastic. If it's not due to those causes, we call it non-megaloblastic, okay. But the MCH is still greater than 100. So causes, we have liver disease, we've got hypothyroidism, we've got reticulocytosis, bone marrow failure, neoplastic anemia there, we've got myelodysplastic syndromes. Okay, so it's very important to know all these conditions. In normocytic anemia, it can be anemia of chronic disease, it can be kidney failure, okay, it can be premier, okay. So all these conditions, okay. So the same thing we talked about when you're evaluating, when you do your own studies for microcytic hypochronic anemia, your main target is serum ferritin there. Serum ferritin can be low. When it's low, it indicates that the carrying capacity of oxygen of iron is low in the body. So that's indicative of what? Iron deficiency anemia. If it's normal, you do other studies and you check for HB electrophoresis, you will find that this anemia can be due to anemia of chronic disease or sideroblastic anemia, or abnormal type of anemia. It can be due to thalassemias. Okay, so serum ferritin, when it's low, just know that it's iron deficiency anemia. Okay, so we talked about this. How does a patient with iron deficiency anemia present? We talked about they can have menstrual problems, menorrhagia, GI bleeding, okay. All those conditions we talked about earlier on. History of pica, they can consume things like clay, chalk, ice, okay. So those things. This is how a spoon-shaped nail looks like, okay. We also talked about the Plummer-Vincent syndrome, which is just a triad, okay. So the presentation of anemia, you can present the patients from head to toe. Okay, in severe anemia, they can be jaundiced. Okay, you know there's increased destruction of red blood cells. They can present with fatigue. They can present with dizziness. They can present with fainting. They can present with low blood pressure. Okay, they can present with palpitations, a rapid heart rate, chest pain. They can present with angina. Okay, even a heart attack. Okay, they can present with weakness, shortness of breath. Their skin can be pale there. They can have brittle hair. They can have angular stomatitis there. Okay, you need to always evaluate all these causes. Okay, so we've talked about the investigations for each type of anemia. Okay, we need to do our iron studies in iron deficiency anemia. Okay, we need to do biochemical tests for vitamin B12 and for folate deficiency anemia. So this is just a picture showing iron studies. We have already talked about the iron studies. Okay, these are just thalassemias. It's just a condition which we'll discuss later, but you need to know it as well, because it's just a syndrome which is inherited when there's a disorder at the alpha and the beta chain. Okay, so we'll look at this condition, but for now, on the peripheral blood smear, just now you'll see a bull's eye appearance. Okay, so we've talked about all these things and we've extensively looked at megaloblastic anemia. We've discussed megaloblastic anemia. So under megaloblastic anemia, you will see under the peripheral blasphemia, you will see hypersegmented neutrophils. So in the MCQ question, when you ask you such a question, just think of hypersegmented neutrophils is found in vitamin B12 deficiency. Okay, so the things that you can say, the biochemical tests will show serum methyl malonic acid will be elevated, and homocysteine will also be elevated in vitamin B12. So methyl methyl malonic acid and homocysteine will be elevated in vitamin B12 deficiency. Okay. You also need to talk about antibodies to the intrinsic factor. Okay, you can also do antibodies. Okay, so you also need to talk about you can do an indirect bilirubin test, which is going to be